But there was a little voice inside my head that said, no, no, you're not going to ignore this.
We prefer that is not done in a doctor's office.
Oh, okay.
Because it actually does, in some cases, delay the situation, delay the biopsy, delay the care.
What other types of imaging options are used in breast?
Awesome. Hi, Jenny. How are you?
I'm doing well. Very happy to be here today.
I am so glad that you're here today and that we are finally able to connect and do this on a beautiful, warm day. I'm in Alberta and Calgary, and you are in?
Sunny southern Manitoba, just right in between Winnipeg and Brandon.
Excellent. Okay, so we have provincial representation, so to speak.
We sure do.
Well, welcome to our listeners. My name is Dr. Efi. I'm the host of the podcast, The Illuminated Darkroom, Conversations on Breast Health and Beyond. And today I have the absolute pleasure of having Jenny. Jenny, how do you pronounce your name? Is it Borgfjord?
But it's Borgfjord, and then you say it fast. Borgfjord. If you think of the fjords in Iceland and put Borg in front of it, you've got my first name.
Jenny Borgfjord.
Or last name.
Yeah, Jenny Borgfjord. There we go. Excellent. That's you. Yeah. Excellent. Okay. Well, I'm going to read a bio, okay? Jenny was born and raised in Manitoba. She's a mother of 3 adult children and mother-in-law to 1, a wife, sister, aunt, cousin, and friend. Teaching is her vocation, supporting accessibility and technology in her school division. She's a cancer survivor. Her diagnosis and treatment complicated by the fact that dense breast tissue masked the presence of the 2-centimeter tumor on routine imaging. She encourages everyone to take breast changes that last more than 2 weeks seriously and to read about and understand their breast density. Jenny's advocacy with Dense Breasts Canada, Know Your Lemons, and Breast Screening Advocates Manitoba focuses on improving education and awareness about breast cancer and screening and advocating for optimal screening and surveillance practices with politicians and bureaucrats. So, welcome again.
Thank you very much for having me.
Okay, well, I think that it's only apropos that before we start, you should let us know, if you don't mind, a little bit about your breast cancer history. When did you find out? How old were you? Was this part of a routine screening situation, or what happened?
Well, my story is about dense breasts. I had 2 screening mammograms prior to my diagnosis, and after the second screening mammogram, about a month after my normal results came in, I was taking care of myself after a shower, and I noticed a lump on my left side, and I thought, that's not normally there. And then I thought to myself, well, but I just had a normal mammogram, so I'm sure everything's fine. You don't have a history of breast cancer in your family. But there was a little voice inside my head that said, no, you're not going to ignore this. So I gave it a week because I thought, well, it could just be some sort of shift. I was already postmenopausal by then, so I wasn't going to blame it on hormones, but maybe something else. And I told my husband, I made him my accountability partner. I said, look, I got a little lump here. I said, we're going to check in on a week. Don't let me forget, because life gets busy. Sometimes these things can get forgotten.
Right.
So I checked back in a week, and lo and behold, the lump was still there. And the little voice inside my head said, pick up your phone, get on your doctor booking app, and see when the next available appointment is. Wouldn't you know what, it was that day. So I was booked my appointment. I sat in my office all day stewing about this because I was thinking, well, they're just going to say, Jenny, you just had a normal mammogram, you're fine. But the doctor didn't. And they tried fine needle aspiration and were not able to successfully withdraw anything. So they made me an appointment for breast ultrasound, which mercifully I got within 3 working days. And at that point, when I was there, and the ultrasound technician was getting a little quieter as she was running the wand over the area with the malignancy, and then she left for a bit to check up on her work, she told me, and then she came back with a radiologist, and I knew I was in trouble. And I was shocked. I was laying on the bed, but my jaw, I think, was on the ground because I didn't think that this was going to be part of my health history because I didn't have a family history of breast cancer. Anyway, the radiologist was able to do a biopsy right then and there. Yeah. She was very lovely, very reassuring. I knew though that she didn't say it, but I was assuming she was suspecting something not so great because she told me things like, oh, we've made really big strides in breast cancer treatment these days and things like that. Mm-hmm. So then I left the biopsy, the ultrasound and surprise biopsy, carried on with my life in a bit of a daze for 10 more days. And when I got the phone call from my doctor, he led into the conversation with unfortunately, and then I knew it was game over. Mm-hmm. And then at that point, I didn't know much about breast cancer. So, right. I mean, I was just going everywhere with, oh my God, am I dying? Like, what's happening? I didn't know that there were so many subtypes of cancers and that they're all different. Fortunately, after my first appointment where they did the fine needle aspiration, the doctor had made an appointment with our local breast surgeon who she has an interest in breast health. So I had already had an appointment booked, so I got to see her. She was able to explain everything to me, and I left there feeling really relieved. Good. It was early stage. Things looked good until the next day. She phoned me and she said, oh, you know what? Because your mammogram didn't show the results, we'd like to send you for an MRI. So I thought, okay, sounds good. Sounds fair to me. So I waited a little while for the MRI. I got in on a cancellation. Was supposed to have my lumpectomy, and then the day before the lumpectomy, the surgeon phoned me and said, unfortunately, the MRI revealed another mass. So you have a choice tomorrow. You can cancel the surgery and have the second mass further investigated, or we can do a full mastectomy tomorrow. Mm-hmm. So I didn't have very much time to make this decision, so I called my husband home from work. We live in a nice small town, so he was able to come home. We talked about it, and we decided that we were going to opt for further investigation. So we canceled the surgery for the next day. And then about 10 days after that, I got in for my second biopsy, and the results came back from that rather quickly that it was actually benign. It was a fibroadenoma. Good. So of course, I dreaded that decision every second that ticked after saying, okay, because I could have had a full mastectomy that day and been, on my way. Mm-hmm. In hindsight, I'm glad now that I waited. The surgeon was very reassuring, and she said, 10 days won't make a big difference. So right. And then 3 weeks after that, I had my lumpectomy. Had a big wait to get into cancer care. Once I finally got there, I had the Oncotype DX test. My lucky number was 16, so chemotherapy was not recommended for my treatment, and I went straight into radiation. Mm-hmm. And I finished that up and started aromatase inhibitors, and so that's where I'm at right now. It's just in okay. Yeah, I guess it's not active treatment. Is it called passive treatment? I don't know. I'm still taking the pills.
Ongoing.
Yeah,
it's ongoing. Yeah. Okay. Well.
So yeah, that's I'm a little bit young, I think, for a white woman to have breast cancer, and I have dense breasts. So that's kind of where.
Those are the two things. Yeah.
Yeah.
Well, thank you for sharing that. I think you definitely mentioned a few things that I want to point out for the listeners. I like, first of all, the fact that you didn't ignore it, which seems
I was tempted.
Yeah, well, it seems like such a silly thing to say, but unfortunately, this happens. And it's no judgment. People are scared, right? If I leave it, maybe it will go away, right? But breast cancer does not go away. I've yet to see it. It does not go away. So I love that you didn't ignore it. You're pretty proactive. And I also love the fact that you had an accountability partner, your husband, to keep you accountable. Yeah. We need that.
Yeah, he was a great support.
All of this. I have a question to ask you. You mentioned you had an FNA. Who did the FNA for you?
Sorry, what's an FMA?
Your fine needle aspiration you mentioned.
Oh,
You mentioned,
okay.
initially you had a fine needle aspiration. Was that done in the doctor's office or was that with a radiologist?
It was with my family doctor.
And that was the one that did not yield.
They did not yield anything.
Okay.
And that's because I think that was his thinking, as well, it's probably a cyst. But then when he couldn't pull any fluid from it, he decided that the breast ultrasound was the way to go.
Well, I wanted to mention this in your story for this particular reason, because I think it would be irresponsible for me to not do that. We see that sometimes where perhaps it is in the interest of saving time where family doctors put a needle in it and in things that you can't see, and it doesn't yield much. And eventually the patient is sent to the radiologist, where now we can use imaging to guide the process, right?
Mm-hmm. That makes sense.
Now, the problem with that is sometimes when we now see the patient, you're looking at a situation in the breast which is changed. Does it look that way because someone stuck a needle in it and it's bled and it looks more complex? Or is that how it was? Is this just a hematoma? Is it a cancer that's being hidden by a hematoma? When I say hematoma, I mean clot. So it complicates the picture. And this is why for us as breast imaging radiologists, we prefer that is not done in the doctor's office.
Oh, okay.
Because it actually does, in some cases, delay the situation, delay the biopsy, delay the care. So we say, if things, we just see things so much better when they're imaging guided, right?
Yeah,
so it's best to not have it done in the doctor's offices.
Thank you. I'll make sure to refuse that if I'm ever offered that again.
Yeah, and I think a lot of our family physician, obviously we love them. They are a huge support, but that's a thing we're seeing now where people are more cognizant of that and sending them to imaging clinics to get imaged rather than sticking a needle in there. Because sometimes, when, for example, we may see a cyst, there may be a vessel beside it. They obviously can't see that.
Right.
There's a bleed.
Yeah.
It bleeds inside the cyst or the mass. Now what are we looking at? It really does complicate the picture for us in a lot of cases.
Okay, thank you. That's great information.
That's good to know. Yeah. And then you mentioned you had the mammogram, then obviously you had the biopsy, but you're saying that there was a mass that wasn't seen.
Correct. Yeah, it was, I don't remember the dimensions. The report told me how far away, and it was quite deep into my chest, and had probably been there for years and years. But so the 2 screening mammograms didn't even pick up that mass.
Yeah.
So,
and we can talk about that later when we go through our questions. In terms of So things are looking good. I'm really happy that you are where you are, and onwards and upwards. We hope that things keep going well.
Yeah, I want to use my privilege and my voice to make sure that this doesn't happen to other people.
Yeah, and I really appreciate you doing that. Now, you mentioned Dense Breast Canada, and you're an advocate for that. How did that happen? I know Jenny, obviously. If you could let the listeners know a little bit of how you started doing work with Dense Breast Canada.
Well, it was basically through social media. I'm a bit of a find outologist. I saw that on Facebook a little while ago. I wanted to know what was going on with me. I went through, I don't know, these stages of making sense of things after my diagnosis. Mm-hmm. For a while, I carried a sense of shame. And I remember hearing about that on one of your other podcasts about the shame that some women feel. And I went through that. I don't know why. So I kind of laid low. I didn't do much. For a variety of reasons, we kept this information quiet. So I was just figuring things out. But then as I started to roll along here, I started thinking about things and my find outologist skills came back to the surface. I wanted wait a minute, that is wrong. What I did what I was supposed to do. I went for the mammogram and the mammogram failed me. And I was prepared to go down that path. But I had also gone on to social media. I went to Google. My cookies must have fed Dense Breasts Canada to me. And then I found them on social media first, and then I went to their website. I read it from each page from top to bottom, top to bottom, top to bottom. And then, so I did this for a couple of months, just back and forth, trying to learn, trying to absorb it, because it's a lot of jargon, a lot of health information that I haven't been trained to absorb. And then one day on social media, Jenny had put out a request saying, hey, are there any advocates in Manitoba that would be looking to work with Dense Breast Canada? And so I immediately sent her a message, and it's been history ever since. I have her on speed dial. She's been very helpful, and she set me straight about the importance of mammograms, because I was teetering down that path a little bit, and I thought, well, no, wait a minute, now I know that I still need to continue to go, and part of our advocacy in Manitoba is to make supplemental screening accessible to women with dense breasts. So
no, that's good. I love Jenny, and I encourage everyone to go onto that Dense Breasts website, because there's a lot of good information on there. Yes, mammograms are great. Of course, you know that there are limitations based on the density of your breast tissue. But even on my social media, I do mention, even with dense breasts, there are things that we still do see. Just last week, we had a patient, dense breast tissue with calcifications. We are still able to see calcifications. And even with 3D mammograms, we're still able to see pathology, abnormal things on mammograms. So it's not a good idea to forego the mammograms completely and just think, oh, I'm just going to go for an ultrasound.
Yeah, she set me straight. Don't worry.
Yeah, so I just thought, it's good for the listeners to know that. And maybe we'll touch on it on our questions. So that's good. Now, and that's how we connected, because I know Jenny as well. And, we have our meetings. And I know you'd reached out. And there are questions that patients generally have that they're curious about, or as a breast cancer survivor that you had. And so we thought this would be a good idea for us to get together. You can ask me some questions and I'll answer to the best of my ability in a very, hopefully, simplistic way. And if there's anything that I say that, it's not clear or basic level, just let me know and I'm happy to clarify it. So do you want to just take it from here and start off with the questions, and let's see what happens? Okay.
This is the role reversal for you right now, isn't it?
It is. You're in charge here. You're asking the question.
Okay, excellent. All right. So, what is the difference between a screening mammogram and a diagnostic mammogram?
Okay. So it's all terminology. A screening mammogram basically means you're coming in, you don't have any symptoms. Screening tests are designed they're supposed to be cheap, cost effective, and beneficial, right? Because if they're really expensive, it would be very difficult for the government to support. So screening tests are done so that a lot of people can have them, and it's done because the value of it is worthwhile. So a screening mammogram is a mammogram that is done to women that have absolutely no issue. And the hope is that if we do this, if there's breast cancer, we can pick it up early so that treatment can happen. A diagnostic mammogram is also a mammogram, but it's being done for a reason. So maybe a person feels a breast lump or notices some changes in their breast, dimpling. Then a mammogram is done, and it's a bit more tailored to the particular concern that the person is coming in with. Okay, so screening mammogram, no issues, no concerns. Diagnostic mammogram, concern.
And it's basically then the same machine.
It's the absolute same machine.
Okay.
The views that are done might be different. Okay.
Okay.
So let's say, for example, like a routine mammogram will have typically 4 images. I say typically in women that don't have implants, as an example. Now, let's say, such as yourself, let's say you had a mammogram, and then you come in maybe 7 months later, and you're feeling a lump. I don't need to do all 4 views now because you just had it 6 months ago. But you have a lump right here in the upper outer quadrant. Now the technologist is putting a marker on it. They're marking where that lump is. There's a mammogram that's done. When I look at that mammogram, that one mammogram, I can see the lump, the marker that she's put. I can see where your area of interest is, and we can look. If there's calcifications there, then we can get extra views. Like we tailor it according to what we see, and then maybe we do an ultrasound. It's just a tailored mammogram because there's a specific concern that the patient comes in with.
And so is the radiologist is then possibly watching what's happening in real time then?
So that's a very good question, actually. Screening mammograms can be done. Patients go into the clinic, get it, and leave. And it's read at another time. With diagnostic mammograms, the radiologist is present and guiding the process. Right? So a patient will have, the technologist will come into the room and say, this is a patient that has a lump. What do we need to do? Actually, typically what's happened is we've already planned what to do, but just as an example, what do we need to do? And then I would say, okay, I look at the previous, okay, this is what's happened. This is her concern. Let's go in there and get additional views. Do a CC view, do a lateral view, or maybe do MEG views. And then they bring it back to me and I look at it. Okay, I'm happy with it. Or, you know what? No, I think she needs an ultrasound. It's more guided, right? Okay. Yeah.
Excellent. Why do provinces have different screening guidelines?
That's a good question. So we live in Canada, obviously, and the federal government has set these national guidelines, but the provinces are responsible for how each guides their health care. And because of that, every province takes a different approach. And that's something that as breast imaging experts in our community, we're trying to fight that so everything is uniform. It's a disparity in imaging in Canada, 100%. It should be the same. Last week, as an example, I had a lady come in. She was from Ontario, and she came in for routine screening for breast cancer patients. So breast cancer patients still get annual screening. In Alberta, we would add an ultrasound depending on the density. She had dense breasts as well. And I had looked at her previous imaging. She had at least 5 different mammograms, dense breasts, no ultrasound. She had her mammogram, which was routine, nothing. She had an ultrasound because she had dense breast tissue. That's it. And the sonographer picked up a 4-millimeter cancer. I went back to her mammogram to see if I could see it. I couldn't see it. I knew exactly where it was on the ultrasound, o'clock, how far it was from the nipple. I had everything that should tell me where it was on the mammogram. I couldn't see it on the mammogram. And the only reason we saw that is because she had an ultrasound. Now, if she was in Ontario, we wouldn't see that. Should it be that way? No. So this is where we are hoping that the government pays attention and patients advocate for it should be the same screening all across Canada. Because like you mentioned, and dense breast tissue, it does have a masking effect on breast cancers, especially small ones, which is what we want to find. 4 millimeters, But yeah, so that's definitely a flaw in the system, and it should not be that way. And we hope that it changes.
And by dense breasts, we mean category C and
D.
Right? Yeah.
Right, yeah.
Not leaving C's behind.
No, not leaving C's behind. There was actually a new paper, I'm sure you saw, for Dr. Gordon, and I think Dr. Seeley was on it as well. I did put it on one of my posts that just showed the benefit of supplemental screening in dense tissue, and included the C's and the D's. So the C's are not forgotten. Absolutely not.
I have to tell you a funny story. So this in the summer of 2023, after I was in the waiting zone to get into cancer care, I decided to fly out to Calgary with my newfound knowledge about dense breasts and everything. And I was going to lecture my cousins out there on making sure that they were getting tested or imaged properly. And they looked at me and they said, "What are you talking about, Jenny? We've known about this for years. We go and we get extra testing." And I was like, "What?" So
yeah, it's definitely. I think I'm lucky we live in Calgary, because if people knew how many cancers we pick up on ultrasound that are not seen on mammograms alone in dense breast tissue, especially the D and extreme Ds, the dense and extremely dense breast tissue. It's a good number. And so we're quite fortunate that in this province we're able to get that. But it should not depend on what province you live in.
No, exactly.
Right?
They knocked me off my soapbox pretty quick, but it also taught me a bit more about dense breasts, so that was good.
Yeah, and we hope that in the future, as we're making progress, that things will change.
Let's hope.
Let's hope.
All right. So from the group, at what age should I start mammograms and how often?
Okay.
Assuming no other history.
Assuming no other history, assuming this is just like regular screening, we recommend to start at age 40 because studies have shown that most lives are saved when you start breast screening at age 40 and every year in an average risk population, meaning that there's no, like you said, no history, just most people are in that average risk category. Now, if you are at higher risk, we can talk about that later, then that's tailored. So as an example, let's say you had a mother that was diagnosed at age 45, for example, then we recommend starting 10 years earlier than when she was diagnosed. So that would be at age 35. But we don't add mammograms earlier than age 30. Okay, so the earliest we would add mammograms would be 30. If there's a breast cancer gene or a genetic mutation, then we would also start breast mammograms at age 30, but they would add MRI starting at age 25. So general population, no history, age 40. And every year.
And that's your optimal, but that's not exactly what's happening, right?
Exactly. Okay. Optimally. Okay. That is that's what us breast experts recommend. Yes, the guidelines are different, but I'm going to tell you what the research and the science has shown is that the most lives are saved starting at age 40 and every year. Now, provincially, things are different.
Yes.
And some people say go every 2 years, but if you ask any breast imaging expert what's the best, they will tell you starting at age 40 and every year.
Thank you very much.
Welcome.
Okay, so what happens if I don't have a family doctor? Can I still get screened?
Absolutely. So the way that a lot of the provinces have done it is that you can, I should back up and say, one good thing about Canada is we do have screening programs, right? Which doesn't...
Oh, and self-referral, right?
And exactly. So that's essentially what I was getting at. Because when you compare it to the States, there are a lot of places, I don't even know if there are any screening programs in the States, but in Canada, we have screening programs. And back in the day, when you looked at provinces that didn't have screening programs, you saw that the breast cancers in women were found at later stages. Okay? So in this screening program means you get called back for your mammograms, but it also means that you can go and get a mammogram without having to go to your family doctor at a particular age. In Alberta, as an example, and I'll speak to where I live, you can start self-referral at age 45. Now, you can start screening at 40, but you have to go see your family doctor first and have that discussion. And then once you enter the program, you can go every year. But to start self-referral and not having to go see a family doctor, you can start at age 45. Some provinces start at 40, some start at 50. And
we're in the 50 range, but not for long. Exactly. We're dropping to 45 in December 2020.
There you
go. What year is it? 2025.
2025. And I know
there's a commitment to 40 in December 2026. So Alberta is going to have some catching up to do.
I know. Alberta definitely has some catching up to do because I think we were one of the first provinces to go to the 40s, right? 45. And now it seems that other provinces are actually dropping down to 40. So yeah, we definitely have some catching up to do. But, it's baby steps. We're hopefully going to get there.
Well, I mean, it's good news that people can still get a requisition to go if they want. So
yes,
I know that can be a barrier, but it's still a possibility.
For sure, it's still a possibility. And I also do want to mention that there are still, like, if you are interested in getting a mammogram, you can still go to walk-in physicians and talk about that and get it. Okay. I know, for example, at my clinic, if you are of the age and you don't have a family doctor, we have an affiliation with a clinic called the Well Women Clinic, and they will see any patient that comes in with a breast-related issue.
Oh, great.
Yeah, so actually this clinic, they're an amazing group of physicians, and just we love them. So if you're 45 and you want to have a mammogram, you don't have a family doctor, they will see you.
In Manitoba, we have a couple, one for sure, a virtual clinic, I guess, so you can hop online. It's called QDoc. And I've heard from some of our Manitoba people that have reached out that they've had some good experiences with them getting a mammogram requisition or things like that. So
yeah, I think for sure what I would say is don't let the fact that you don't have a primary care physician dissuade you from getting a mammogram. If you do call even most breast imaging clinics, they will probably have some information for you as to how you can go about getting it, or how you can go about getting a requisition or coming in to see us. So family doctors there, it's hard for a lot of people to get a family doctor, and which is why it's somewhat of a disservice what the task force has recommended. Go talk to your family doctor about it. Well, not everybody has a family doctor. And our family doctors are, overworked and underpaid, and it's not a perfect system, which is why, I always say knowledge is power. Learn how to fight for yourself and get what you want. There are definitely ways to get what is best for you.
Yeah. Going in prepared for sure. Educated and prepared is one of my strategies.
Absolutely.
Okay, well, we'll move along here. What is average risk, and how does that differ from high risk? And how does a person know which one they are?
Okay, so you're considered average risk if you don't have any personal family history of breast cancer, if you don't have any genetic mutation, like, things like the BRCA1, 2 gene, if you don't have a strong family history, if you haven't had any radiation therapy to your chest. So this is most women that are out there. Most women are average risk. And your higher risk, the opposite. If you have a known family history, if you've had a biopsy that has shown a high risk lesion. So there are things such as atypical ductal hyperplasia, atypical lobular hyperplasia, pathologies in the breast which are not breast cancer but put you at a higher risk for that. Okay, so we will look at you, we'll screen you a little bit more carefully. If you, like I mentioned, have that genetic mutation, BRCA1, 2, leaf-for-many, there are other, genetic Lynch syndrome, there are other syndromes as well. If you have had radiation therapy to your chest, before the age of 30, so maybe you've had lymphoma and you've had that puts you at a higher risk. So that's the difference, right? And we kind of touched on it briefly. If you're at a general average risk, we just recommend starting screening at age 40, but if you're at a higher risk, of course, that changes. Now, how do we know? Obviously, there's a lot of women that are walking out there and like, I don't know what my risk is. How do I know? And that is definitely, it's a concern. And sometimes people find out coincidentally, or, when you hear, oh, my mom had breast cancer and her mom or her sister and two of her sisters or three of her sisters, or a brother or a father, something's off. And when you also add, well, maybe they had ovarian cancer as well, like there's a generational, lots of people, that's kind of unusual. It should start to spark that question. I wonder if my risk is high or low.
Definitely good to know your family history.
Exactly. But the reality is a lot of people don't, right? And what if you're adopted? You don't know that, right? Yeah. Exactly. And that is a problem, of course. Now, there is also something called where you can get your risk score. When I say that, do you know what I mean?
Are you talking about the IBIS?
Yeah, the IBIS or the Tyrer-Cuzick. So if you go on Google, people can just check risk calculator IBIS or Tyrer-Cuzick, and I'll put that in the notes. And it comes up with a questionnaire. And it asks you a bunch of questions, your age, and when did you have your period, when did you start menopause, family history, what kind of density you have, just a bunch of different questions that you can answer to the best of your ability. It's not a perfect system, but at least it kind of gives you some idea of what your risk is, right? And if you land in that 11 to 12, 13%, that's an average risk. If it starts to get higher, 20% or more, you're of a higher risk. I think in Ontario, it's actually higher, maybe 25%, but I'll have to.
And I guess it gives you something to talk to your doctor about too.
Exactly.
Like if you print off the report and say, here, you take a look at this.
Exactly.
Just to spark the conversation.
100%. And, ideally you do it with your primary care physician, but it's also something that you can do yourself, and for higher risk people, so Black women, Ashkenazi Jewish women who are at a higher risk, it's recommended that you do this risk calculation at least before the age of 30, ideally by age 25, to find out what your risk is.
Oh, that's good information.
Yeah.
Okay. And do you repeat it? Do those risk factors, can they change over time?
Of course they can change over time, right? It can change depending on family history. I think probably a more recent example, I know I've seen it on social media where we always talk about celebrities. Beyonce, I mean, her father had the breast cancer gene, and then her mother. So with her father having that breast cancer gene, her risk is higher, right? So when she would go into that risk calculator, it would ask, does your mother have breast cancer history? She would have said no. Well, now we know that her mother had that, right? So when she redoes that test, her risk is even higher. So she's got a fairly high risk of it. So that number can change. And so it's always a good idea to check it when you have any known change in information that you have.
That makes total sense. Okay, so what are dense breasts and why do they matter?
Dense breast tissue. Oh, yes. It's a hot topic. It matters because, mammograms are great, and breast imaging experts will also tell you that there are limitations. When we as radiologists are looking at breasts, we categorize them into 4 categories. So there's A, which is fatty, means that most of your breast is fatty tissue, and B is scattered, C is heterogeneously dense, and D is dense. And the difference is in these numbers or alphabets is that breast tissue is made up of fat and glandular tissue. Let me just keep it that simple. The more fat you have, the easier it is for us to see if there's a cancer, because cancers will always appear as white on a mammogram. Fat is black. So if you have a cancer that's white, on a dark cancer, we'll see it. The more glandular tissue you have, the more white your breast tissue is. So the more of that glandular white tissue you have, if you have a small cancer that's white on white, it's a masking effect. It's harder to see, right? So that's why it's important to know your density. Mammograms they are great, but like I said, there are limitations in assessing the dense breast tissue. But there are things that have been able to help us. I mean, we've moved along technologically. It used to be 2D, now there's 3D, so we can see better, but just having dense breasts in and of itself does increase your risk of breast cancer, period. So that's another reason why you should know what your breast density is. And in where you can, it's advised to get supplemental breast screening, whether it's by ultrasound. Some places do MRI, some places do contrast enhanced MRI. It just helps. They complement one another, and it's not to say that, I have dense breast tissue, I'm not going to have a mammogram. No, you definitely, we know that, right? You need that mammogram, but we need to add to the mammogram to complete the picture.
Yeah, it's just like anything in education. You have to triangulate your data to get a good picture of what's going on. So I can see how that would make sense in healthcare as well.
Exactly.
And speaking of, for those visual learners out there, if you want to have a visual representation of what Dr. Efi is talking about, you can go to that Dense Breasts Canada website, and right on their homepage, they have a nice graphic of all 4 types of breasts on there, and you can follow or try to look for the white cancer in all of them,
right, as it's going. Yeah, I'll also when I edit this, when I post it, I'm gonna try and put some examples of cancers that were not as I'll show the density and also show what a dense tissue looks like, and a cancer that's hidden on dense breast tissue and what it looks like on ultrasound. Yeah. So that's
Awesome.
what dense tissue is, and that's why it's important. But I tell you, for sure, the more mammograms you read, the more experienced you are, of course, and I know that there are some numbers out there where the number is like really high. If you have dense tissue, it's masked. But I would say that all in all, mammograms are actually quite good, even in dense breast tissue, for sure.
Okay. That's very reassuring.
Yes, indeed.
Okay. Well, I think you've already answered this one. The question from the group was, if I have dense breasts, do I need extra screening? So I guess that's going to be a case-by-case basis, and it depends on where you live.
It depends on where you live right now. But
Yeah.
I would definitely try and at least ask the family doctor to ask for an ultrasound and go from there. Advocate for yourself, because
I guess so. And in my home province, do that sooner rather than later. Unfortunately, we have some pretty long wait lists now. So, you know what? Get proactive and
yeah. And I do hope, hopefully some places will be looking into getting whole breast ultrasound as well, which helps speed the process up. As you know, I mean, all over the world, in the States, in Canada, we have a shortage of manpower. And with handheld ultrasounds, it's sonographers that are doing it. I think before COVID, after COVID, even fewer graduates are being brought out of sonography schools, and it's hard to find sonographers. But with a whole breast ultrasound, it doesn't have to be an ultrasound tech that's doing it. So this is a tool that would be a great alternative, and it's still an ultrasound to help screen dense breast tissue. It's excellent, actually.
Is it economical too?
Mm-hmm. Yeah.
It sounds like it might be. But
I mean, ultrasound is expensive, whichever way you look at it. ABUS, I don't know what the exact numbers are, but when you have an ultrasound machine, and we're kind of veering off a little bit here, but just really quickly, when you have an ultrasound machine, ultrasound comes with different probes, right? Depending on where you want to scan. So those probes are quite expensive, and an ABUS machine is expensive as well. But when you consider the cost of using a sonographer, maybe it balances out. And I always say exactly how much is your life worth? Who cares how expensive it is?
I don't have a problem with the price, but some people do.
Exactly. And I mean, that's the way I look at it, so it's expensive, but, we use it well, and it is very useful. I found 4 or 5 millimeter cancers on ABUS.
Right. And we know from Dr. Wilkinson's and Seeley's research that treating breast cancer early is far more economical than finding it and treating it at a later stage.
Exactly. So. way, way more economical. Again, I'm going to put it on the finished product here. It's much more economical, but also it's
for the women,
better for the patient. Exactly. Yeah. It's the difference between having a lumpectomy versus a mastectomy, for having chemo or not, lymphedema. I mean, it's a no-brainer, right?
Yeah. Oh yeah.
Yeah.
I know that we have great treatment, but boy, I would love to see better screening, optimal screening.
Yeah, for sure.
You've sort of addressed this next question, but I'm going to say it anyway because it was from the group. What does heterogeneously dense or extremely dense mean in a report?
So, like I mentioned before, it's that A, B, C, D, and I think we go 20. We kind of go 25, 50, 75, and 100, right? So, and then when I use those numbers, I'm talking about percent of dense tissue. So the C and D are at the higher end, over 50% of dense tissue. Whereas so the heterogeneously dense would be 50 to 75% amount of dense tissue, and the dense would be over 75% amount of dense tissue compared to fat.
Right.
Right. So it just means you have more glandular tissue than fatty tissue, which makes it harder for us to find cancers. Just more of a masking effect. And it also just puts you at a higher risk of breast cancer.
Yeah. Okay, and then should I be using the IBIS? Sorry, is that how you say it? IBIS or IBIS? How do you say it?
Tomato.
Okay, the risk calculator.
The risk calculator, IBIS. I say IBIS, but I mean, who knows?
Okay.
Yeah, IBIS is what I say. Tyra Cusack. Yeah.
Okay. I wasn't sure I could say Tyrer either. Tyrer.
Yeah, I know. It's a bit of a tongue twister. Tyrocusic, TC, IBIS, go on Google and put it on there, IBIS risk calculator. And it's definitely worth looking at and seeing what your risk is. Yeah, for sure.
I actually did mine, and I plunked in the before cancer stats, and I came out at 14%. So even if you're doing that, you still need to be vigilant about other things as well.
Absolutely.
So I wouldn't have been considered high. We don't have, I don't know if we do this in Manitoba or not. I haven't done it with my doctor, but
you're 14% after having cancer.
No, I did.
Before?
I put in my stats, but it's my understanding we're not supposed to do the IBIS after if we have a history of it.
Yeah,
so I put in my stats before cancer.
Okay,
and that's what I came out. And of course, I'm harassing my daughter to do it. I have she's 26, so that's something I ask her almost every time. Is, hey, have you done that yet?
Yeah, it is important I'm glad you mentioned that, because we're seeing more and more breast cancer in young people. So it is important I have 2 young girls as well, and, I always encourage them, you guys know how to do a self-breast examination. And it's not too early to start. You've seen my podcast I've done a podcast now with, there's one that's coming out yet, but a 24-year-old, I think a couple months ago I had a 22-year-old.
Shayla?
Yeah. A couple months ago I had a 22-year-old. That was, I couldn't believe it, and I think the youngest I've seen is 19. Yeah. So, we are seeing breast cancer more and more in young people, and, knowing your risk, doing your self-breast examination, those things are obviously important, right? Yeah.
I could throw in a plug there for the Know Your Lemons app. That's a great app. Unless you have other thoughts about it, but it teaches you, you record it, cyber secure. It teaches you, tells you what you should do if you find an abnormality, those kinds of things. So
yeah. And I just did I don't know if you saw it, I did a video on how to do self-breast examination as well.
I sure did.
Yeah. So I will put the link on here as well so people can see, because I don't want people to get stuck on, it's not a super technical thing. It's just the point is know your breasts, right?
Yes, know you're normal. That's
know
what I tell
you're
people.
normal, because dense tissue can feel ridgy, nodular. Fatty tissue can feel ridgy, nodular. Do you know how many women that come in and be like, oh, I have dense tissue?
Yeah.
You do a mammogram, completely fatty.
Yeah.
So it's just, but you know what's normal for you.
And that's what I do little Know Your Lemon sessions around my community. And that's what I tell them. I said, you're not on a hunt for breast cancer. Right. You're just getting to know your normal, so that when, or if someday something does become out of the normal, you're going to be better prepared for that.
Exactly.
And that was accidentally my situation. So that's why I'm pretty passionate about it.
Were you doing exams before that?
Not very regularly, because I had conversations in my 40s. I was told I was too young for breast cancer. I didn't need a mammogram, and they wouldn't do clinical breast exams anymore. And I didn't really need to bother with the breast self-exam anymore. And you know what? I didn't question it. Yeah. And I'm kicking myself now. But
yeah, it struck me too how you mentioned the shame, and I hate that for people, because you could do everything right. Yes. And still get breast cancer. Like everything right, plant-based diet, you name it. Mm-hmm. So, of course, it's easier said than done, but there's literally no reason why a woman should feel, first of all, that, oh, they've done something to cause breast cancer, because
I think that was my biggest issue, that I had felt that my lifestyle wasn't what it should have been.
Yeah, well, if we had the magical answer, trust me, we'd all be on that. We don't.
Yeah.
Right.
I have certainly met a lot of women, though, who had the optimal lifestyle that also are in the breast cancer club.
That's right.
I know that now.
Yeah, so that's good to know. I just want people to know that. Don't think that you've done something wrong. And at the same time, I feel like I should also mention, there are women that have breast cancer and they are ashamed because maybe they've waited and they see this lump and it's growing and it's growing. And I tell you, Jenny, I've seen women that come in with fungating cancers and they just embarrassed. They don't want to show up. Just show up. Just show up. Yeah. Nobody's judging you, because the mind it's just crazy thing that can make you think whatever. And denial, it's real. Anxiety, it's real. but just do your best, show up, and we'll take it from there. There'll be no judgment.
Yeah.
You know? Yeah.
That's lovely to hear.
Yeah.
Very reassuring.
Yeah, for sure.
I certainly have felt that along the way for myself. No one has. Yeah.
The girls are good, you know, the technologists, when you come in, they're just excellent. And it's like, nobody's asking you, oh, why did you wait this long? And all, it's like, no, you're here. Because oftentimes what happens is it's the patient that's making the excuses, so to speak, or trying to tell us to justify why they waited that long. It doesn't matter. Like, nobody's here to judge. You're here now. Is the point. Nobody's here to judge you. Be like, oh, you should have. No, you're here. And we'll take care of it and move it along. That's it. Yeah. Well, so if you're sitting there listening to me, I always want to tell people, if you're sitting here listening and you're in this situation, please just make that appointment and show
just get
up.
there.
Just get there. Yeah.
Bring a friend if you can.
Yes.
I did have one, actually, can I tell if I have dense breasts by feeling my breasts?
No.
I kind of thought that might fit in too.
No, absolutely. Yeah. No, you cannot. So the only way you can tell what your density is by having a mammogram. It's by imaging. It's not something,
not ultrasound.
No, not ultrasound. Well, you know what? On ultrasound, we can see your density. We can tell if you're extremely dense. But it's still not, we can tell if you're extremely dense. We can tell if you're fatty too, but the best way to do it is by getting a mammogram. And, you know, like I said, there are even some requisitions that I get where the doctor has put, extremely dense tissue, lumpy, and then we do a mammogram, the patient's completely fatty. So it's not even something that your family doctor can tell, you know, by feel. This is really an imaging finding.
So get that mammogram.
Get that mammogram.
As soon as you're eligible. Or if you have a symptom, get in, right? Don't wait till you're 50 or 40 or 45, whatever the right is. So
Exactly.
Okay, good. So you mentioned 3D mammography or tomosynthesis. Did I say that right?
Tomosynthesis. 3D tomosynthesis. Yes.
Is it better than 2D?
You know what? I would say yes. Yeah. And really, again, in Alberta, most places are doing 3D mammograms now. I doubt that there'll be a place that's going to be doing 2D. So basically, 2D mammogram is what most people know as a regular mammogram. It's been around for a while now. Before 2D was when you'd have a mammogram and you would look at it on film. So that's analog, right? Did you have those?
No, I think I've never seen my imaging, but now I think I want to go. I wouldn't know what I was looking at, but
I'm actually going to try and put one up. Yeah. So we used to have it when I first started, like my career, you know, it used to be all on film. So analog. And then we moved it to digital. That's 2D, where you just have the compression, the picture is taken, and it's on a computer. Now, in addition to the 2D, you'll see the tube kind of go across your head like that. And what it does, it's kind of like looking at a mammogram, but lots of slices of it. So it gives us a better
like cross sections,
kind of like a cross section.
Did in biology?
Thin slices, exactly. Slices, exactly, right? So it just gives us a way better view of the breast tissue. And it reduces, it used to be back in the day on a 2D mammogram, you see an area like, is this, like, what is this? The patient's going to have to be called back to get spot views. With 3D, we don't have to do that. As much, right? So it's definitely, I find, we see things like distortion, which is where kind of the breast tissue pulls in, and that could just be the sign of breast cancer. And we see it a lot better on 3D. So I think it's much better. And there used to be a concern of, it's more radiation. No, it's not, because it used to be before that people get a 2D and then a 3D. Now you just do a 3D, and from there we generate extra views. So the radiation amount is not as high. It's better. Yes.
Okay. Excellent. Thank you.
I'm a big proponent of 3D.
Big proponent. That's good to know. What other types of imaging options are used in breast care?
So we talked about ultrasound, and breast ultrasound we use for supplemental screening, and we also use it to guide for biopsies, right?
Oh, right. I didn't have that, I don't think.
You didn't?
Well, I had the ultrasound, and then so she kind of knew where it was, and then she put the needle. Mind you, I'm gonna maybe mention that I was in a bit of a traumatic state at that moment, so maybe I don't remember it properly.
Because I'm wondering how yours got biopsied then.
Well, maybe she did, and I wasn't paying attention.
It's amazing.
I'm gonna tell you, I was a little elevated in those moments.
It's kind of interesting you say that. Sometimes patients come and like, have you had a biopsy before? And then they're like, I don't remember. I'm like, you know what? You don't need to remember that. We have your history. Yeah. There are a lot of things that people need to remember. This is, if you want to forget having a traumatic experience, that's okay. We do have people's files that we can access as we need to find your history.
Right.
So
that's probably just as well.
Yeah. So exactly. So we use it to guide biopsies as well. Now there's breast MRI as well. That it's for specific
I have
uses.
one of those.
It's not to replace a mammogram. And then there's contrast enhanced mammography, which it's a newer technology that it's a mammogram, but they add contrast and, abnormal tissue lights up. And some people actually, like, the research has shown it's almost as good as MRI. Some people prefer, and
that's exciting.
Obviously there's pros and cons, and that's it. Yeah. So those are the different alternatives. There's like nuclear medicine, but in terms of screening type studies, those are the ones
keeping in mind screening versus diagnosing. That was definitely a learning curve for me. I didn't I thought a mammogram was a mammogram. So I've learned a lot for sure.
These tools are all these different modalities, they're complementary to each other. Right?
Well, that's
they're not
a great
one
way.
in place of the other. Right.
Great. So what is QT imaging then?
Okay, let me just see. Make sure that this is okay. Good question. Now, there have been some new modalities that are being spoken of lately.
I see them on Instagram.
Exactly. QT imaging is one of them. Thermography is another one. So QT, it's a newer thing. It's ultrasound, and it's not something that's in Canada. There are some places that are in the States, but it doesn't have any radiation. It can produce 3D images, but the fact of the matter is, it's not as good as finding calcifications. If you look at the papers or the so-called research on it, they only looked at a small subset of women, I think 60 or so people that have had cancers. This is something you have to pay for. It's not a replacement for mammograms. Okay. Period. It does not find calcifications. It just isn't. People naturally, of course, you want to go for what's easiest, but easiest is not necessarily the best. It's not at all anywhere ready to be replacing mammograms, and you have to pay for it too, I guess, in the States. Like, I don't know anywhere that has it in Canada.
Okay. I think some of the questions coming up here are about discomfort from mammograms. So some people might be interested in the QT imaging because of that, but it's not recommended.
And here's the thing. So you do it, and there's something that's seen that who knows what it is. Then what? What do you think's going to happen next? You're going to have to have a mammogram. Yeah. Because no surgeon is going to treat you based on any result from a QT image.
Okay.
So that thing that you're trying to...
That's an important point,
right.
Actually.
You're going to have to go and get it.
What are the next steps? Yeah.
Next step is going to be a mammogram. Okay, you see something, I'm not sure what it is. Or then they'll say, I think I've heard in the States, they'll be like, okay, well, we can follow up with another QT image. And you've just got to pay for it. You've got to pay for the first QT, you got to pay for the second QT. And, but most importantly, it's not a replacement for mammograms. Okay. It's the same thing with thermograms. Thermograms,
That's the next question.
So exactly. Thermograms.
Let her rip.
Well, yeah, it's in the, I guess, the alternative medicine realm where this thermography uses radio frequency, and the idea of it is that the thermogram picks up heat from the cancer, and that's how they find cancers. Now, I got to tell you, a lot of cancers do not have heat. How do you get heat? It's vessels. A lot of them are not vascular. So there's a lot of women that come in, oh, the thermogram found something. And when I say they've come in to get a mammogram, because now you have something on thermogram, what happens? Same thing with the QT. You got to have a mammogram to see what's going on.
So you may as well save yourself some money and go straight to the mammo.
And then you do a mammogram, there's nothing. Or alternative, we have women that come in for mammograms and then they'll be like, oh, well, I had a thermogram and it was fine, but they have a huge cancer sitting there.
Yikes.
I encourage people to go online and look at the FDA news release. I printed it off. This is if FDA issues a warning letter to clinic illegally marketing unapproved thermography device, warns consumers to avoid using thermography devices to detect breast cancer. And so it says that the U.S. FDA has issued a warning letter to this clinic and its president and its owner, basically warning them that thermography is not cleared by the FDA as an alternative to mammography, and it should not replace mammograms for breast cancer screening or diagnosis. You do your research. It's not a replacement tool for mammograms. Period.
Thank you very much. That's good to know.
Okay. So we're back. This is maybe going to be part 2 because we've been talking for a while. So I thought maybe, might be a good idea to split this into 2 sections. So let's do part 2 and continue with the Q&A. What do you have next?
Mammograms are a big topic.
Yes. Thanks for being a guest on my podcast, and to everyone that's listened, thank you. I look forward to sharing the next episode with you. Please follow me on my social media platforms at Dr. Ify Women's Health for upcoming episodes and more. The discussions and opinions shared on this podcast should not be considered medical advice. If you have any concerns or symptoms, please consult your primary care physician.